There we go. Hello and welcome, everyone. We're delighted to have you join us today. This webinar will be recorded, and the recording and slides will be sent to you via email sometime after the webinar. During these live presentations, please excuse cameos from canine colleagues and other unexpected moments. We hope this doesn't happen, but if the webinar were to close unexpectedly, please reopen it from the link that you used to attend this presentation. We welcome questions. We will respond to your questions during the Q&A session after the presentation is done. Please type in questions at any time using the Q&A box at the bottom of your Zoom window. Closed captioning of the presentation is also available. To show or hide the transcript, click on the up arrow on the live transcript button that is also at the bottom of your Zoom window. Please note, for those viewing on a phone or a tablet, the Zoom app currently highlights only the active speaker. The live transcription will still be available. You may need to scroll to the left or right to see the presenter or the presentation. For privacy during the presentation, all participants are in listen-only mode with microphones muted, and chat between participants is unavailable. If verbal clarification or participation is necessary, where you need to use your audio, please click on the hand icon at the bottom of your Zoom window to raise your hand, which lets us know that you'd like to speak. Someone will unmute you, and a prompt may appear asking you to unmute yourself. This action will temporarily turn on your microphone so you can ask your question. One last note, if you are posting to social media about what you learn here, please tag us and use the hashtags that will appear momentarily in the chat. Once again, this webinar will be recorded and the recording will be sent via email. I will now introduce to you Dr. Michelle Mead, who will moderate this webinar and assist the panelists with any questions or comments. Dr. Mead is a principal investigator and director of the Rehabilitation Research and Training Center on Investigating Disability Factors and Promoting Environmental Access for Healthy Living, IDEAL RRTC. A full professor at the University of Michigan Departments of Physical Medicine and Rehabilitation and Family Medicine, and co-director for the University of Michigan Center for Disability Health and Wellness. Michelle, the floor is yours.
Thank you very much, Corey, and welcome everyone to this wonderful webinar. Make no bones about it. There is more to skeletal health than bone density, and we have much to learn. This webinar is being sponsored by the IDEAL RRTC, which stands for the Investigating Disability Factors and Promoting Environmental Access for Healthy Living, which is funded by the National Institute of Disability, Independent Living and Rehabilitation Research. The mission of the RRTC, and hopefully it will show that in a second, is to understand and enhance healthy aging of people with long-term physical disabilities, especially those at risk for poorer outcomes because of a lack of resources, severity of disability, location, or other circumstances. And we do this through research and knowledge translation activities. Our overall vision is that we want to recognize and address the social determinants that impact health and healthy aging for the individual with long-term physical disabilities. We conduct the research. We have 5 multi-part research projects. We conduct education and training activities. We do knowledge translation and provide technical assistance. This webinar is part of both the educational and knowledge translational activities. Please check out our website to learn more. And finally, I wanted to inform you about our 2 upcoming webinars and ask you to save the date. In January, we have a presentations on broadband internet access and the implications for the health of individuals with disability. And in April, Dr. Michael McKee will talk about reimagining primary health care for individuals with disabilities. I will let Dr. Whitney share his screen. But in the meantime, please join me in welcoming Dr. Dan Whitney and Dr. Edward Hurwitz for their presentation. Dr. Whitney is an assistant professor in the Department of Physical Medicine and Rehabilitation here at the University of Michigan. He received his PhD in applied physiology, studying musculoskeletal pathophysiology in children with cerebral palsy and has been conducting research about the bone health of individuals with pediatric acquired disability since across the lifespan. Dr. Hurwitz is the James W. Ray Collegiate Professor and Chair of the Department of Physical Medicine and Rehabilitation, as well as a pediatric physiatrist who has gradually developed expertise in seeing individuals with pediatric onset disabilities for across their lifespan. And so both are well aware of the health and healthcare disparities that this population experiences. With that, I am going to turn the floor over to them, and I will be monitoring the question and answer and chat boxes and will help facilitate questions at the end. Dr. Whitney?
All right, well, thank you very much, and thank you very much for having us. We are very excited to be here. The title of our talk is Make No Bones About It. There is more to skeletal health and bone density, and we have much to learn. This is being presented by myself, Dan Whitney, and Dr. Ed Hurwitz. So there are three aims to today's talk. We're going to first introduce bone fragility as a public health issue, but we'll talk beyond the excessive monetary costs and rather how bone fragility is implicated in loss of function, morbidity, and mortality. The focus of today's talk is on abnormal bone development and how that impacts bone health across the lifespan, and really in the context of disabilities. In aim 2, we'll introduce some basic fundamental principles of treating bone as a complex adaptive system. Once we better understand the different ways that bones can grow and are maintained across the lifespan, we'll then begin to talk about why the current clinical methods to assess bone fragility could really be insufficient for people with disabilities. In aim 3, we'll wrap up and we'll present clinical scenarios of the different sort of pathways to structural bone fragility. We'll discuss pediatric conditions that have completely different reasons for their abnormal bone development. Now, the goal of aim 3 is to highlight how treating bone as a complex adaptive system can reveal new insights into the structural mechanisms underlying the bone fragility. And we hope with these new insights, it can motivate future research into developing better clinical monitoring, screening, and treatment strategies to really get at what the bone actually needs. Now, we really hope that we can deliver the take-home message that while bone density really is important to understand bone strength, there is more to bone than density alone. And I try to make that rhyme like a catchphrase. I hope that sticks. So in aim 1, we'll first introduce some basic terminology. So bone strength and fragility sit on opposite ends of the same spectrum. Bone strength refers to the ability to withstand forces to prevent fractures, and therefore bone fragility is some arbitrary threshold at which bones are breaking under normal loading circumstances. So think about things like fracturing from a wheelchair transfer or fracturing from a fall from seated or standing height. Now, bone is composed of two major types of bone tissue. At the ends of long bones, we have what's called trabecular bone. This is made up of individual trabecular structures that are interconnected, and they form a honeycomb-like appearance. What encompasses the bone is cortical bone, and this is a thick, dense tissue, and it's predominant in the shaft of the bone, or that's also referred to as the diaphysis. Now, you're going to hear me refer to strength and fragility phenotypes throughout this talk, so I wanted to give us an idea of what this might look like. Now, please understand that phenotypes can be very individualized, but hopefully this gives us some sort of idea of what I mean when I say strength and fragility. So the strength phenotype on the left is a thick, dense cortical wall. It has a high concentration of trabecular bone. The trabecular structures are thick, they're interconnected. In the fragility phenotype on the right, there's a thin cortical wall, not a lot of trabecular bone. The structures are thin, they're not connected. This person is more likely to fracture from a seated height, for example. So then the question is when does bone fragility emerge? Well, it's well studied in the elderly years and in the menopause transition, but the focus of this presentation is on abnormal bone development, which refers quite simply to when typical bone development goes awry, or when something should be happening, but it doesn't, or it doesn't to the same extent. Now, how the bones develop during growth sets the stage for lifelong bone health. So when bones develop abnormally, bone strength may not be sufficiently achieved by the young adult years. And additionally, the bones can become weaker a lot quicker. Now, unfortunately, abnormal bone development in some form or another is not uncommon for individuals with disabilities. So we really need to be thinking about bone health well before the menopause transition in the elderly years for these populations. So another question is, how common is abnormal bone development? I mean, are we talking less than 1% of the population? Well, it turns out that there are several pediatric conditions with known or suspected abnormal bone development that can occur through a variety of direct and/or indirect pathways. While individually these pediatric conditions can be uncommon and some are even rare, collectively they account for a considerable portion of the pediatric population. To highlight this, we accessed nationwide data from the US. This sample here includes children who were 2 to 25 years of age that had continuous private health insurance health plan enrollment in the year 2017. And in order to identify conditions, we required these children to have at least one healthcare service utilization in the year of 2017. Well, of the 1.4 million children, 43% or 2 in 5 had at least one pediatric condition associated with abnormal bone development. And this group accounted for nearly 80% of all the fractures that year. Now, studying fractures in the pediatric years is a really rare event. So this is really compelling about the harmful effects of abnormal bone development in the pediatric years, but it gets worse across the adult lifespan. Now, to provide a lifespan example, we're presenting a fracture risk across the adult lifespan from 26 years of age to over 70 years of age. We're using data from adults with cerebral palsy. The reason we're using this pediatric onset condition here is because we just published a study, so we were able to reuse some of these figures. And what we're looking at is fracture risk by these narrow age bands, by about 3 to 4 year age bands from 26 to over 80 years of age. Women are on the left, men are on the right. The top black lines are the cerebral palsy group, and the gray lines is the general population without CP. So what we're looking at here is that fracture risk is already elevated in the young adult years, undoubtedly influenced to some extent by the abnormal bone development, but fracture risk continues to climb and at points exponentially climb compared to the general population without cerebral palsy. Now, what we're finding is that these sort of fracture risk profiles are actually present in other adult populations that have pediatric onset conditions. So it's not unique to cerebral palsy. Now, what's particularly concerning is that adults that have abnormal bone development, they don't just have an increase in early risk of fracture, but they seem to have this excess post-fracture health decline. So the conceptual model that I'll present here comes from our own evidence from adults with various neurodevelopmental disabilities. And what we're finding is that when these adults sustain a fracture, they have this substantially increased risk for cardiorespiratory diseases and mortality, even after accounting for a variety of confounders. Now, what we know is that when you get a fracture, it could lead to loss of function. It can also trigger a cascade of a series of events that leads to biological alterations. And this might be driving this sort of premature morbidity and mortality burden that we're seeing. But these post-fracture health declines also increase risk for a new subsequent fracture. So really, this could just accelerate these negative health spirals. So in summary of AIM-1, abnormal bone development affects a considerable portion of the population. It increases bone fragility across the lifespan, which in turn increases premature risk for loss of function, morbidity, and mortality. And the question is, how do we prevent this? Well, one way is to go back to the roots of the problem and to better understand how and when the bones are becoming fragile so we can develop interventions that have a lasting effect. In order to do that, we need to really better understand the different ways bones can be developed during growth and maintained across the adult lifespan. And once we understand that, we'll then tackle why our current clinical methods to assess bone fragility can really be insufficient and not positioned to detect bone fragility for individuals with disabilities. So let's first introduce typical bone development. This is a complex multifactorial process. It's informed by a gigantic interacting network of genetic, biological, and an array of environmental aspects. Bone development has unique priorities at different stages to form certain structural bone traits. And collectively, these processes harmonize to establish the permanent structural basis of the bone's framework. Some of the structural adaptations include increasing the mass and the size of the bone, defining the shape, and defining and refining macro and micro architectural aspects of the bone. Before we move forward, I wanted to quickly talk about how we're going to represent the diaphyseal phenotype, so the shaft of the bone. So this is a magnetic resonance image from a typically developing child. This is an axial view. That white outer ring is the subcutaneous fat. That gray in the center is the muscle, and what's in the red circle is the femur bone. Here, black is cortical bone. That circle inside is that bone marrow cavity. So how we're going to represent this diaphyseal phenotype is just with an overly simplified donut shape. We're not going to worry about the perturbulations or the unique shapes of bone. So in this diaphyseal phenotype, gray is cortical bone, white is a bone marrow cavity, and the surfaces matter. The outer bone surface is referred to as the periosteal, and the inner bone surface, or the surface that separates the cortical bone from the bone marrow cavity, is referred to as the endocortical surface. Just to give you an idea about how we might differentially represent these phenotypes, this is an example image from a child with severe cerebral palsy. You can see that the thigh is a lot smaller, really underdeveloped muscle. And this red circle is the same size, which really shows the vast underdevelopment of the femur bone. So how we might represent this diaphysis is with a smaller donut shape. Now this figure represents telescoping growth patterns of the diaphysis from 8 years of age to 16 years of age, all the way on the right. The space between these donuts, or the diaphyseal phenotypes, represents what must have happened to go from one phenotype to the next with growth. And the color matters. Black represents bone formation, or bone is being added, which can occur on both surfaces. Red represents bone resorption, or bone is being removed. And blue represents this sort of balanced, steady state. So let's dive into these growth patterns. So this is an example, a representative diaphyseal phenotype of a typically developing 8-year-old boy. As they grow, the outer bone size increases primarily through bone formation, but there's this coordinated biological adjustment on the inner bone surface so that as the outer bone size expands, the marrow cavity expands accordingly. Now around puberty, there's a substantial increase in the outer bone size, but then the bone biology changes on the inner bone surface such that bone is now being added to the outer and inner bone surface. Now these coordinated processes aim to support the development of two very important structural traits. First, an increase in outer bone size. Well, outer bone size is a major determinant of fracture risk. Using basic biomechanical principles, bone strength is related to outer bone size raised to the 4th power. What this means is every increase in outer bone size, there is a substantial increase in bone strength. Second, bone development aims to increase the cortical thickness of the wall. And here I'm showing from the periosteal to the endocortical surface. A thicker cortical wall leads to a stiffer and stronger bone. Here's an example of typically developing girls. And just looking at the colors and the timing of the colors, we can see that there's a slightly different biological strategy used, but it still aims to accomplish a similar sort of structural trait set. That is, increase in outer bone size and increased cortical thickness. Well, it turns out that the complex nature of bone development is actually more complicated. So we're starting to see that bone growth completely differs based on the bone's phenotype. Now, it's certainly up for debate on how you want to define a bone phenotype, but we work with Carl Jepson in the Department of Orthopedic Surgery, who has been largely successful in studying the different ways bones can be constructed during growth and maintained across the adult lifespan from the context of bone robustness. So Dr. Hurwitz and I are really excited because we feel like we finally have some sort of vantage point or anchor to study abnormal bone development, and specifically how and when bones become fragile. And this is not purely an academic exercise. This has large clinical implications. Once we know how the bone should grow and when it's not and how it's not, that should really help tailor monitoring, screening, and treatment strategies in the future. Now, bone robustness is a multi-trait measure. It describes the transverse expansion relative to linear bone growth. So how we would capture that is outer bone size divided by bone length. Now, bone robustness is thought to be largely determined by genetics by about 2 years of age. So when you are 2 and you have a certain bone robustness phenotype, you're probably going to carry that for the rest of your life. However, the studies that helped to form that conjecture were in typically developing children. And we suspect that bone robustness and its determinants may be a little bit more complicated in the context of disability. Now, in the general population, there is a substantial variation in bone robustness, ranging from narrow to wide phenotypes. The femurs below represent what these bones might look like from a narrow, intermediate, and a wide phenotype. And the circles below show how we're going to represent these sort of diaphyseal phenotypes. Now, what makes bone robustness so attractive is that it actually takes away the effect of different sort of body composition profiles. So we can study this in men and women, in children and adults, because outer bone size and bone length are both influenced by body mass and height. But by taking the ratio, we're actually removing the effect by that. And studies have found that very large people have a range of narrow to wide phenotypes, and very small people also have a range of narrow to wide phenotypes. Now, it turns out that there are completely different biological strategies used at different times to form a different set of structural traits, all of which is dependent upon that bone's adaptive needs, which can be predicted by that bone's robustness. Now, when I first introduced bone development, I used this intermediate bone phenotype in the middle. Now, to keep things as simple as possible, what I'll do is I will contrast the narrow and the wide phenotypes, and I will introduce the bone's basic adaptive needs, and then I'll talk about the major compensatory strategies that it uses. So a narrow skeleton will sense that it is narrow, and it will realize that it is automatically weaker because it has a smaller external frame. So the adaptive needs of a narrow bone is to increase stiffness of that tissue. It does this by setting forth a unique set of biological strategies that leads to a higher degree of mineralization, which I try to reflect here by the darker shade of gray. And it also aims to develop a proportionally thicker cortex. Now, on the other end, wide bones recognize that they're wide and that they're automatically stronger because of their larger external frame. So the adaptive needs of wide bones is to actually minimize the bulk and the overall mass of it. So it does this by setting forth a unique set of biological strategies that compensates to develop a lower degree of mineralization and a proportionally thinner cortex. Now, all of these sort of bone adaptations, this is what goes on in the general population. And all of these are healthy adaptive mechanisms that really optimizes the strength for that bone phenotype. So children with wide, intermediate, and narrow bones, so long as they have these adaptive mechanisms, these bones are not going to fracture under normal loading circumstances. These children can play sports, they can fall off jungle gyms. As long as nothing is so high impact, these bones are not going to fail as long as they have these healthy adaptive mechanisms. And one thing that we're really excited about is we feel like we finally have a template to study abnormal bone development. And we can use this to better understand how and when bones become fragile. So as an example, let's say there's a child with a disability who has a narrow phenotype. We see at 8 years old, they have their phenotype at the diaphysis is on par with what we'd expect for a narrow bone. Let's say we measure them at 12 years of age, and we see that the outer bone size is smaller than what we would expect. Well, this might tell us that there was issues, there's not enough provisions to support bone formation. prior to 12 years of age, not allowing for that outer bone size growth. So we might think of some osteogenic stimuli to really just try to support what that bone was naturally trying to do. And the importance of this is some of these traits are really not adaptable after certain periods in the lifespan, especially during growth. So if you're 12 and you start with a small bone, if you don't change, you could end with a small bone by 14 years of age, and there may not be any sort of catch-up. So another way to put it is, for some of these traits, there's a deadline on intervention. Now, on the other end of things, for a wide bone, let's say there's a child with epilepsy and they switch anti-seizure medications to maybe one that's associated with excess bone resorption. We monitor their diaphysis at 14 years of age, and then we measure it again at 16. And we see that the outer bone size doesn't change, but there's a thinner cortical wall. Well, that might tell us that there was too much bone resorption at that endocortical surface, and that we really need to be considering adjunct anti-resorptive therapies so that child can retain that cortical thickness and carry it through with the rest of their life. Now, I wanted to talk about just some very basic adult aging compensatory mechanisms. I'm going to keep this very, very simple. Adults with narrow bones actually see an increase in the outer bone size, but it's small, something like 10 to 20% from 18 years of age to 70 years of age. But while it's not as drastic as what happens during development, these sort of fundamental structural adaptations are really important to maintain bone strength with aging. And if you, just as a reminder, bone strength is related to outer bone size raised to the 4th power. So these minor increases in outer bone size yield a large increase in bone strength. It's probably a very unique mechanism that's important to narrow bones to maintain strength with aging. Now, on the other end, with wide bones, the outer bone size doesn't seem, according to a couple studies, doesn't seem to change across the adult lifespan, but the path to fragility for wide bones is one of resorption. So excess resorption at the endocortical surface could lead to a cortical wall that thins from the inside out, and that would create a weaker bone. There's also evidence of excess cortical porosity. And cortical porosity just refers to empty vacant spaces where bone could be. So a thinner, more porous bone leads to a weaker whole bone mechanics. Now, the first line pharmacological treatment for bone fragility is anti-resorption agents such as bisphosphonates. Theoretically speaking, not clinically because this hasn't been tested yet, but theoretically speaking, people with wide bones may respond really well to anti-resorptive therapies. And that's because this anti-resorption would block the resorption and allowing for that cortical thickness to be retained and to mitigate the cortical porosity. But these same therapies may not be very effective for people with narrow bones. And that's because bone biology is really intimately tied. Bone resorption and formation crosstalk and they communicate with one another. So anti-resorption therapies would block or reduce the resorption, but that may also reduce the bone formation. The bone formation is what the outer bone size increase is really driven by that bone formation. So anti-resorption therapies may be blocking a necessary trait compensation of that outer bone size for narrow bones. Now, I do want to say this is the reason I bring up these sort of treatment things is really just to highlight how understanding these different bones, how they grow and how they become fragile, can really give us some insights on how they might be responsive to different sort of therapies. But this is an overly simplified view, and what's known about this already is there's still a lot left to discover. So I really don't want anybody to stop taking their osteoporosis drug if they're taking one, just because of all this theoretical stuff that I'm presenting here. Now, Dr. Hurwitz at the end will come in and talk about some of the clinical concepts. So you can direct your questions to that as far as that goes. So when taken together, bones can grow in completely different ways. And they can form a unique set of structural traits that optimize bone strength for that bone's phenotype. But some of these traits can be completely opposite of one another. And some of these are shown in the table here. So how can a single clinical method with one range of values detect bone strength for everybody? I don't know. What makes matters worse is that the current clinical assessment methods really just focuses on one of these structural traits, and it's the mineralization of the bone mass. So we end up missing out on a lot of important information that can tell us more about the structural composition of what makes that bone strong and what makes that bone fragile. And we can see here that a healthy, narrow, and sufficiently strong bone is going to naturally compensate with a higher mineralization, and a healthy, adapted, sufficiently strong wide bone is going to compensate with a lower degree of mineralization. So let's talk about this a little bit more. So the current clinical assessment methods to detect bone fragility really focuses on bone mass, or that mineralization component. Measure bone mass, it's commonly used with a DEXA scan to identify the bone mineral density, or BMD. This raw BMD value gets standardized, converted to a standardized score. And based on thresholds, you'll be diagnosed with normal bone mass, osteopenia or osteoporosis, or low bone mass for children. So then the question is, does BMD capture bone strength? And the answer is no, it does not. And yes, it does, and maybe. I'm going to present a couple of scenarios to really highlight what DEXA BMD is measuring and the shortcomings of it for people with disabilities and abnormal bone development. And I think we'll start to see that for a lot of people, DEXA BMD is really kind of shooting in the dark as far as it capturing bone strength. So in this first example, this is actually not what goes on. This is assuming no size mass integration, because I'm trying to make a point, which I'll get to in a second. So what I mean by this no size mass integration is we had just talked about how narrow bones have a higher degree of mineralization to compensate for a stiffer bone, and wider bones have a lower degree of mineralization to compensate by minimizing its overall bone mass. So let's assume it's a similar mineralization across the bone size spectrum. Well, a DEXA report spits out three values: the bone area, which is the outer bone size here, or relates to the bone size, the BMC, the bone mass, and then the BMD value. Now, the BMD value is a ratio of BMC divided by area. So if all of these bones have the same extent of mineralization, that means they have the same BMD value. So we can see here it's just arbitrarily 0.92. Now, the problem with this is clinically it would be tempting to interpret as these three bones having equal bone strength. But we know that's not true, because we know the wider bones are mechanically stronger than the narrower bones. So the take home from this hypothetical situation is that BMD does not pick up on the attributable fracture risk by bone size. And the area measure is there, it's just not interpreted. Now, what's more likely to happen in the general healthy adaptive state of bone is that narrow bones actually have a higher degree of mineralization so that they can be stiffer, which would reflect with a higher BMD, 0.98 here as an example. And wider bones adapt by having a lower degree of mineralization, which means a lower BMD. Now, the take home here is that BMD for narrow bones, it would be clinically tempting to interpret as stronger than they actually are because of the higher BMD value. And as I'll present and talk about in a little bit, individuals with pediatric onset disabilities are more likely to have this underdeveloped bone size. And so when it's poorly mineralized, it's like a double whammy to bone weakness. It has a small external frame that's insufficiently stiff. And why this becomes important is because a narrow bone that presents with maybe an average BMD value should really flag that that's actually insufficiently mineralized for its narrowness. If it was appropriately mineralized, it would have a much higher BMD value. So your patients that present would have a narrow bone that present with an average or slightly below average BMD, likely have a very insufficient degree of mineralization for what it should for a narrow bone. Now, BMD for wider bones, it would be clinically tempting to interpret as weaker than they actually are because they're presenting with a lower BMD value, despite potentially having a sufficiently strong skeletal framework. Now, as a third general scenario, individuals with disabilities are more likely to fracture in trabecular-rich regions. So at the ends of bones, think like around the knee, distal femur, and the hip. What I'm presenting here is in these boxes here, is magnetic resonance image of trabecular bone microarchitecture from typically developing children in the strong phenotype in children with cerebral palsy in the fragile phenotype. Now in these boxes, white represents the trabecular bone. So we can see in the fragile box, there's a really low concentration of trabecular bone. These trabecular structures are disorganized, they're not connected. This might explain why the distal femur fractures or fractures in the distal femur are so common in children with cerebral palsy. Unfortunately, DEXA does not pick up any information about trabecular bone. DEXA also does not pick up information on the cortical thickness or the cortical porosity, which are also major determinants of fracture. So for people with disabilities and abnormal bone development, the clinical consequence of BMD assessment alone is on one end under detection, leading to missed opportunities for early intervention. It's going to be primarily for people with narrow bones who have or are at risk for bone fragility. They might present with an average or slightly below average BMD, but really, if their bone was sufficiently mineralized, it should be much higher. This is also going to be a problem for people that have structural trait deficits that are not reflected in the BMD value, like the trabecular bone impairment. On the other end, it can lead to false positive diagnosis for fragility, leading to inappropriate clinical actions. This is going to be predominant for those with wide bones who would present with a low BMD despite potentially having a sufficiently strong skeletal frame. So in summary for AIM-2, there are completely different ways in which the bones can grow, and they form completely different structural trait sets that are could be completely different across the robustness spectrum. Unfortunately, our current clinical assessment methods are really not positioned to pick up on these sort of trait compensations and abnormal bone development, potentially explaining why bone fragility goes missed for so long for these populations. All right, so AIM-3 will wrap up and we'll present some clinical scenarios of different pathways to structural bone fragility. We'll present pediatric conditions that have different reasons for their abnormal bone development. And the goal of this is to start to highlight how treating bone as a complex adaptive system can reveal new structural insights into the underlying bone fragility. We hope that this can be used to motivate improvements in clinical monitoring, screening, and treatment for bone fragility based on what that bone actually needs. And some of the data we'll present in these pediatric populations, unfortunately, includes groups that are like 5 to 17 years of age. So we're not going to be able to map out these sort of longitudinal trajectories. And really, we're only presenting like an average effect for that sample. But I hope by doing this, we can kind of inspire some creativity in thinking about how you might think about your own patient populations and their bone health and what might be contributing to their structural weakness that goes missed or not looking at DEXA scans. So the two conditions, we had more, but for the sake of time, we'll just talk about two. Osteogenesis imperfecta, OI. This has a direct pathway to bone fragility through a genetic disorder of collagen, which is a building block of bone. And then we'll talk about cerebral palsy or CP, which is an indirect pathway to fragility through motor dysfunction and altered biology. Now, a commonality linking these two and many other pediatric conditions is they're clinically labeled as low bone mass conditions. And we rhetorically ask, is this sufficient in the clinical setting? Now, on one end, clinically, it might be important to label these conditions as low bone mass so that the physician can have some sort of indication that this patient needs routine orthopedic care and assessments. But on the other end, is labeling a low bone mass falling short of then motivating further tests to look at more about the structural mechanisms contributing to that bone fragility. So this is going to be a building slide. We're going to build from left to right. This is the key or the figure. This is just an example of what a healthy, adaptive, typically developing narrow and intermediate and a wide bone might look like. And I try to capture the major trait compensation. So that narrower bone has a proportionally thick cortex and a higher degree of mineralization, again, reflected in the darker shade of gray. Now, OI is a connective tissue disorder, abnormal collagen and bone material, and it ranges in severity. Now, a lot of studies have found that OI, the bone in OI has low BMD, high cortical porosity, and impaired trabecular bone microarchitecture. A recent study directly investigated bone robustness and found that this cohort on average had a slightly narrower bone compared to the controls. But they actually had higher proportional cortical thickness. So in an overly simplified pathway to fragility for OI, in addition to what we know about the poor bone material, is that the bone in OI is on average narrower. In and of itself, a narrower bone doesn't mean bone weakness, so long as it's employing sufficient compensatory mechanisms. One of them is a higher degree or a thicker cortical wall, and the bone in OI seems to be accomplishing that. And the other is a higher degree of mineralization to make that bone stiffer, but the bone in OI does not seem to be doing that. So how we might monitor and screen and treat the bone in OI might be a little bit different than the general population. We might want to think about when that outer bone size starts to lag behind, so we can maybe apply some osteogenic stimuli to help that outer bone size grow. We might also want to focus on the mineralization and understand the interplay between bone formation and biology at certain times that leads to this under mineralization. Now, CP is a neuromuscular condition. It results from damage or malformation of the developing brain. It ranges from independent ambulation to the use of a wheelchair. So I'm going to present two phenotypes, a mild on the left and a more severe on the right. Now, what we know about the bone in children with CP is low BMD and impaired trabecular bone microarchitecture. Cortical porosity has not been looked at yet, but I would suspect that it would be a little bit higher. Bone robustness has also not been published yet in CP, although we have some preliminary data that has helped support some grant applications in mild CP where we looked at this directly. And then I was also able to go to the literature and pull some data from tables and figures to provide an indirect assessment of some of the things I'll talk about here. So what I'm finding is that children with CP on average have a slightly narrower bone, which is even narrower for more severe CP. They also seem to have thinner cortical walls, which is not what you would expect for a narrower bone. So in an overly simplified pathway to fragility, the bone in CP seems to be on average narrower, which again, a narrow bone doesn't mean bone weakness, so long as it has appropriate compensations. One of those compensations is a higher degree of mineralization, which the bone in CP does not seem to be doing. And the other compensation is a proportionally thicker cortical wall, which the bone in CP does not seem to be doing. So similar to OI, we might think about osteogenic stimuli to help build that outer bone size appropriate for that person's size and bone length. But different than OI, we might have to think about why that bone is thin from that inside out. And that might be a sequential or a multi-modal formation resorption strategy to increase the outer bone size and retain that cortical thickness. So again, I just wanted to highlight these to show how we might monitor these bones and what we would look for to identify what makes these bones weak and how this can inform future research investigations about what might work to augment bone strength in these populations. And with that, we now move on to the clinical side of things, treatment options, and I will pass it off to Dr. Herbert.
Thanks, Dr. Whitney. I'll just take a few minutes just to make a few comments about that. So Dr. Whitney presented some of the work that we've done that has really shown that fracture is a very significant problem that can lead throughout the lifespan to disease and actually early death. So it's something that we have to be very aware about. The problem is that the classic way of looking at treatment of bone fragility and fractures is to wait till somebody has a fracture and then treat them. That's the classic adult model for people that are aging. The issue is that we know that individuals with cerebral palsy, osteogenesis imperfecta, many other pediatric-onset disabilities are going to have low bone density. So we want to think about treating them earlier. But the question is how to do that. So we can think about some of the things that any of us would just do naturally, which is tell people to be more physically active, stand more, put more stress on the bone by being active. Well, certainly if a person can do all those things, then that's a no-brainer. We should be doing that. But what if those things are difficult or complicated? Let's take the case of a 16-year-old teenager who uses a wheelchair for all of their mobility. Standing is a very difficult procedure, which involves two physical therapists who put them into a standing frame. And it takes 20 minutes to put the teenager into the frame and 20 minutes to get them out. and they stand there for a half an hour. At the same time, that teenager is a straight A student and is heading for law school, but we keep pulling her out of class. Is that the right thing to do? Is that half hour of standing a few times a week actually going to help her? We don't know yet. And that's one of the things that we need to find out with the research that we're doing. So at the same time, we're fortunate to live in a time where we can do things like DEXA scans and so forth and get this information. But as Dr. Whitney pointed out, they're not so simple to interpret to us right now. And that's where the direction of the research is going, where we want to look at the full idea of what the DEXA scan is telling us. We're used to using one number, how much mineral, how much calcium, for example, is in the bone. And that's not really adequate for us to understand treatment. That's especially true for treatments like medications. You may ask, why don't we put all of our patients on osteoporosis medications since we know there'll be a fracture risk? Well, the answer is those medications have complications. And an even bigger answer is that based on the work and what Dr. Whitney's presented, we don't know which medication is right, and some of the medications may actually cause damage. So there's a lot of questions that we have about this, but the important issue is that we need to help people to understand the problems of bone fragility. We need to think about better ways for treating them, especially for patients who have difficulty with being active, maintaining proper nutrition, and some of these simple things. And we need to understand the role of medications and the role of physical activity, which is not so easy to bring about, like I just explained, in helping with bone fragility and how we treat it. So Dan, if you want to just do a little wrap up and then we can take some questions.
Thank you. Okay, take home message. There's more to bone than density alone, and we have much to learn. We'd like to acknowledge the team that helped us with this webinar. We really appreciate it. It's very easy to work with everybody, so thank you. There's a lot of people to thank on the scientific side of things, but we listed some names here that have been involved directly with this work. One name I'd like to highlight is Carl Jepson, who's really been the thought leader in driving these concepts that we presented in the typically developing population, and that we now get to use as a template to understand how and when bones become fragile for individuals with disabilities. And here's our contact information. Thank you for your time.
And thank you, Drs. Whitney and Hurwitz, for a very thorough explanation of a very complex issue. We have some issues in the chat, but it starts with, what are the early indicators that there are bone issues or problems that may be observed?
Well, that's the problem. And there's two things that come to mind. One is a fracture. That's the first thing that tells us usually that there's a bone fragility issue. But the other early indicator that we know of is the diagnosis itself. So as clinicians who work with these problems, we know that people with cerebral palsy and with spina bifida and with other pediatric-onset disabilities, and in the adult world, people with spinal cord injury and so forth, are going to have bone fragility issues. So we need to be aware of that and think about what's the proper time to start looking at this in our patients.
Okay. There was a question, can you put the slides in the chat or provide the link where we may get them, or if you would feel comfortable putting these on the website? I know that the recording of the film itself of this webinar will be available for individuals. Another question, what is the expected time course of bone density and growth change in response to osteogenic interventions?
Dr. Whitney, you want to comment?
Yeah, it's a good question. And I think one of the take homes from this is BMD a good marker to monitor change? Because BMD is a ratio. So you have a numerator and you have a denominator. And some of these different sort of interventions might affect the mineralization, so the numerator of the BMD ratio, and some might affect the architectural size, that would be the denominator. So if you do an intervention and you see an increase in BMD, well, if that's a higher degree of mineralization, then that's a great increase, and that's the bone is probably getting stronger. But you also might see an increase in BMD because you might be blocking that bone size growth. And so you're actually preventing that denominator from growing, which is itself an independent risk factor for fracture. So a gain or a loss in BMD could either be positive or negative. So we don't know the time course, but what we really need to do is figure out what do we need to be looking at.
And I guess then, I'm sorry. I was
Go
going to
ahead.
say,
Go ahead. Go ahead,
um,
Jeffrey.
are there then either existing norms or attempts to create norms for these different populations, since you're now saying that there are different models that you're now using and the normal metrics don't apply, that we have to look at different relationships?
Dr. Whitney and I joined with that group that he put on the last slide to submit a large grant to the National Institute of Health to do just that, Dr. Mead, to try and look at creating norms, not only in the adult pediatric onset disability population, but in other populations based on some of the new findings and some of the information that Dr. Whitney presented. So that's our goal, to come up with new norms that will inform treatment.
Good. There was a question about, could osteostimulation include pulsed electromagnetic frequency therapy? And the question from Carla is just curious if the US is starting to use this for bone growth and recovery, as she sees units slowly being accepted by the public.
It's a very interesting question. I am not aware of the use of this technique for bone growth. I'm aware of electrical stimulation, but not magnetic stimulation. Dr. Whitney, any awareness of this?
No, I mean, I've heard of like electromagnetic fields to help bone growth. And I guess the question is, what is the bone naturally trying to do? And that's really what, as far as developing the norms, first we have to see how the bone grows. And then we can start to track, what is that bone trying to do, at what time, and what trait is it prioritizing? And these, I don't know what the electromagnetic fields do, but if it's a bone formation, then maybe it's really effective at a time where a trait is being developed primarily through bone formation. So it's still, again, it's this interaction of timing and what that bone is naturally trying to do. And what the bone naturally tries to do is going to differ based on that bone phenotype.
And a question from Lindsay was, what are some of the other technologies or assessments coming down the pipe to better assess this?
I can take a first crack at that, Dr. Hurst, if you don't mind. So DEXA is not the worst thing. It comes with area. It's just we don't interpret area. So, work is going to have to understand how the size and the mass integrates across this size spectrum. So we might be able to harness what we already have, but there's better technologies that dive a lot deeper into some of these sort of structural aspects. Magnetic resonance imaging, computed tomography comes to mind. I don't know if these are necessarily new, but I think they are technologies that are being used in the research setting to eventually get to the clinical setting. Dr. Herbis, do you have any more comments there?
What we don't have is the cheap, simple way to do this. We don't have the machine that I have in my clinic that I can do this quickly on, and that's what we need.
Okay. And how should we monitor children with cerebral palsy?
So that's a great question that we don't have a good answer to. Certainly, anyone who has a fracture should get a DEXA scan, but then if they don't have a fracture, at what point should they get a DEXA scan? And that will depend somewhat on how mobile they are. If a child is more mobile, has more walking function, spends more time on their feet, there's probably less risk of fracture. On the other hand, that child puts themselves in more situations where they can get a fracture. So if we get them involved in sports, should we do a DEXA scan? What will we do with that information? We don't have this all down yet, and there's no clear consensus about this as of yet.
Okay. And to follow up on the question about the technologies, it was specific thoughts about to better assess the cortical thickness, porosity, and organization of the bone, as opposed to just what's provided by the DEXA.
Oh, I see that now. Still magnetic resonance imaging. That's how I was able to get some of this trabecular information that I presented. Porosity, there are new and emerging technologies to do that, but again, these are on the research side of things. Organization, computed tomography, high resolution is actually really good for identifying detailed structural information, but MRI can do that as well to some extent. And so there are big push from radiologists, radiology research trying to get this into a clinically easily, used sort of protocol. So hopefully we'll see that in the next decade or two.
Great. Is there a correlation between nutrition, such as calcium intake and bone density? And based on the current knowledge that you have suggested for an aging population, whether or not this is with pediatric onset conditions or not?
There is, and we recommend a healthy diet for everyone. But if you want to talk about calcium supplementation or vitamin D supplementation, I think it's important to have a discussion with your physician as to your particular case. But there certainly is a correlation with nutrition.
Okay.
If I may add on that, there's a myriad of factors that are affecting bone. And so whenever we look at, especially in cerebral palsy or other developmental disabilities, where there are so many factors at once, isolating one and looking at the correlation with bone densities, we're going to be really missing the bigger picture of things. So nutrition matters, definitely, but it's just one of many, many factors.
And I think that is the message you've driven home, that there are many factors and many of them we still have to understand, we have to study, but at least now we know that there are different models and different approaches that we need for these different populations and groups who are more at risk.
That's right.
Thank you to both of you, Drs. Whitney and Hurwitz, for your very comprehensive presentation and for illuminating this complex issue for all of us. We are about at the end of the webinar. Please, you will be sent the evaluation as well as the slides. Please complete that. You can ask any additional questions at that time. And once again, this information will be posted on the CDHW website. Finally, please join us for future webinars in January and in April. Thank you very much for being here, for your attention and your participation. Have a great day.